Welcome to the Gas Permeable Lens Institute Keratoconus Module, Part 1. I'm Christine Sint, Associate Professor of Clinical Ophthalmology and the Director of the Contact Lens Service at the University of Iowa Hospitals and Clinics Department of Ophthalmology. Keratoconus is a clinical term used to describe the condition in which the cornea assumes a conical shape. The corneal thinning induces irregular astigmatism, myopia, and protrusion, resulting in impaired vision. Keratoconus is thought to be a non-inflammatory disease, although inflammatory molecules, interleukin-6 and tumor necrosis factor alpha, are overexpressed in the tears of subclinical and keratoconus eyes. Increased MMP9 levels were found only in keratoconus eyes, indicating that the pathogenesis of keratoconus may involve chronic inflammatory events. It is generally accepted that there is an incidence rate of approximately 1 in 2,000. However, recent data using current diagnostic instruments shows an incidence closer to 1 in 500. It is seen in approximately 5% of patients seeking refractive surgery. There is no significant gender difference, and it affects all races. It is rare to have unilateral keratoconus. Most cases progress to involve the other eye in over 10 to 20 year period. Topography will often show a subclinical or form-fruste pattern in the good eye. The classic onset of keratoconus is around puberty. However, it can be first diagnosed at any period during one's life. It generally continues to progress over a 10 to 20 year period of time. Studies suggest an autosomal dominant pattern of inheritance with variable expressivity in some families, with up to 25% of relatives having one or more keratoconus traits on elevation-based topography systems. The Collaborative Longitudinal Evaluation of Keratoconus Study, or CLEC study, is a multi-centered natural history study of 1,209 patients where keratoconic patients were examined annually. Its goals were to prospectively characterize changes in vision, corneal curvature, corneal status, and specific quality of life. Best corrected contrast visual acuity showed a decrease in high and low contrast acuity. 19% of patients demonstrated a decrease of 10 or more high contrast letters over the 8-year period of the study. 31% demonstrated a decrease of 10 or more low contrast letters. Corneal curvature. Over the 8-year period, there was a 1.6 diopter increase in the flat meridian. 24% of subjects demonstrated an increase of greater than 3 diopters. Corneal curvature. There was an average of 1.6 diopter increase in the flat meridian. 24% of subjects demonstrated an increase of greater than 3 diopters. Corneal scarring. There was an incidence scarring rate of 20% over the course of the study. This was associated with younger age, corneal staining, steeper baseline corneal curvatures, contact lens wear, poorer low contrast visual acuity, were all predictive of corneal scarring. The CLEC study showed that people with keratoconus reported significantly impaired vision-related quality of life, as measured on the National Eye Institute Visual Function Questionnaire, similar to people who had severe macular degeneration. A 10-letter decline in high-contrast binocular visual acuity or a 3 diopter increase in corneal curvature were associated with significantly larger declines in vision-related quality of life. Keratoconus is associated with significantly impaired quality of life that continues to decline over time. Keratoconus has often been associated with systemic and ocular diseases. In the literature, keratoconus is commonly associated with Down syndrome, between 5 and 15% of people with Down syndrome expressing the keratoconus traits. It also occurs at a higher frequency in other mentally delayed individuals compared to the general population. Possible explanation for this includes genetic abnormalities resulting in structural or biochemical changes, or a higher incidence of eye rubbing. Corneal hydrops associated with keratoconus also occurs at a higher rate in these populations. The literature also supports a higher incidence rates of connective tissue disorders such as Ehlers-Danlos syndrome. Hypermobility of joints has been demonstrated in up to 50% of keratoconic patients. Numerous ocular conditions, such as floppy eyelid syndrome and vernal conjunctivitis, have been reviewed in the literature. McMahon et al. Reported that Leber's congenital amaurosis patients with a CRB1 mutation may be particularly susceptible to keratoconus. While rare, other corneal conditions can coexist with keratoconus. In a study published in Cornea in February 2009, which looked at 52 cases of keratoconus with concomitant corneal disease, Fuchs dystrophy was the most commonly associated condition, accounting for 27 cases, or 52.9%, followed by anterior basement membrane dystrophies and posterior polymorphous dystrophy. Pellucid marginal degeneration may be a variant of keratoconus, and they are often confused. Thalassellus syndrome is defined as an association between keratoconus, magnesium deficiency, type A behavior, and allergy. There is conflicting reports in the literature regarding the association between mitral valve prolapse and keratoconus. In a large controlled study, atopy was found in 35% of keratoconus patients, compared to 12% of controls. Eye rubbing is frequently associated with keratoconus. Keratoconus patients tend to rub very aggressively, frequently with their knuckles or palms of their hands. In patients who deny eye rubbing, family members will often tell you a different story. Ocular responses to eye rubbing include increased corneal temperature, epithelial thinning, increased concentrations of inflammatory mediators in the tears, abnormal corneal enzyme activity, large intraocular pressure spikes, high hydrostatic tissue pressure, decreased ground substance viscosity. In other words, the proteoglycan gel is squeezed out from the center of the cornea to the periphery during rubbing, buckling and flexure of the collagen fibrils, and slippage of the collagen fibrils, and a general change in the keratocytes. Evidence shows that some forms of keratoconus may be preventable. It is recommended that to cease eye rubbing in keratoconus patients to prevent further progression. The genetics of keratoconus is being heavily studied, although many candidate genes have been suggested. As Dr. Rabinowitz aptly put, the greatest challenge to understanding the genetics of keratoconus is the great variability in the phenotypic expression of the disease and the timing of its onset. Genetics seem to play a role in keratoconus when we look at twin studies, the bilaterality of the disease, family aggregations, and formal genetic analysis. Comparison of incidence in monozygotic and dizygotic twin pairs suggest that heredity is involved. However, monozygotic twins are not fully concordant, suggesting non-genetic factors must also play a role in its etiology. In the published literature, there are at least 18 sets of monozygotic twins in which one or both twin show some degree of keratoconus. Although most reports in the literature on twins strongly support a genetic origin for keratoconus, a formal prospective twin study comparing monozygotic versus dizygotic twins without bias must strengthen the argument. Keratoconus is also thought to be a bilateral disease. This makes the genetic possibility stronger when considered that corneal dystrophies are usually bilateral. Corneal topography shows only 0.5 to 4% of keratoconus patients are truly unilateral. 50% of clinically normal fellow eyes will progress within 16 years. In the CLEC study, 14% of keratoconus patients showed a positive family history. There are higher rates in homogeneous populations, up to 23% in Finland, New Zealand, and Tasmania. The keratoconus prevalence in first-degree relatives is a little over 3%, which is 15 to 67 times higher than in the general population. The evidence of keratoconus being linked to multiple chromosomal regions is consistent with a multiple susceptibility gene model. All genes having a small or moderate effect in determining the pathologic phenotype as observed in complex diseases. Multiple genes may explain why we see differences between families, variability, and penetrance. Environment also determines how genes are expressed. Keratoconus corneas have decreased levels of fibronectin, laminin, enactin, type 4 collagen, and type 12 collagen associated with the epithelial basement membranes. There are also increased levels of fibrosis-associated extracellular matrix such as type 3 collagen, tenascin C, and fibrillin 1 in the regions of the anterior stromal scars and disrupted Bowman's layer. Many of these extracellular matrix changes are not keratoconus specific, but related to general scarring, since similar matrix changes are also found in subepithelial fibrosis and scarring regions of bullous keratopathy and failed grafts. Within a single keratoconus cornea, the abnormalities are not uniform. There are areas where basement membrane components are absent, reflecting regions of increased proteolytic activities. In other areas, there are deposits of fibrotic matrix components, but in general, these are not keratoconus specific since they are found in wound healing and other diseases. Thinning could result from corneal stromal cell apoptosis or the activation of matrix degrading enzymes. Apoptosis is the programmed cell death that occurs in development, disease, and wound healing. Apoptosis is important in the normal cellular turnover of many healthy tissues. Animal studies show that chronic, repetitive removal of the corneal epithelium can stimulate stromal apoptosis. This is significant because keratoconus corneas are likely to have chronic irritation due to contact lenses, vigorous eye rubbing, and atopy. Matrix-degrading enzymes, such as matrix metalloproteases, or MMPs, decrease extracellular proteins, while tissue inhibitor of metalloproteases, or TIMP1, inhibit matrix metalloproteases as well as inhibit apoptosis. It is likely that keratoconus corneas have an imbalance between the corneal MMPs and the TIMP inhibitors. Keratoconus corneas have increased levels of MMP2 and decreased levels of TIMP1. Simply put, decreased enzyme inhibitors will increase enzyme activity, which in turn degrades the extracellular matrix and eventually causes stromal thinning. Another theory on stromal thinning is the cascade hypothesis. In the cascade hypothesis, the keratoconus corneas have underlying defects in their ability to process reactive oxygen species and thereby undergo oxidative damage. This triggers a series of downstream events that ultimately lead to thinning and loss of vision. Anything that induces cell damage will increase reactive oxygen species in the cornea. Keratoconus patients lack the necessary enzyme components to process these reactive oxygen species. This results in cytotoxic byproducts. Cytotoxic byproducts result in altered protein functions, which lead to a cascade of events, including degraded TIMP1s, increased apoptosis, and increased enzyme activity. Symptoms are often present before signs. Even when a patient can see 20/20, they are often affected by ghosting and halos. It is suggested that the presence of vertical coma on wavefront is often the earliest sign of keratoconus. As seen in this picture given to me by a keratoconus patient, this patient sees the vertical coma, which shows as a doubling of the vision. There are numerous signs of keratoconus. External signs include the V-shaped bowing on the lower lid when a patient looks into down gaze. This is a late sign seen only in advanced cases. Rizzuto's sign is the cone-shaped focusing of light at the limbal margin. Using a pen light shining on the temporal side, anterior to the iris plane, light rays will illuminate the nasolimbal area evenly in the normal eye. In early keratoconus, light rays are focused sharply inside the nasal limbus. I have often first suspected keratoconus based on the retinoscopy reflex. An oil droplet or scissoring reflex demonstrates the irregularity of the optical path. Slit lamp findings include apical thinning, an iron deposit or Fleischer's ring, which may be partial or may encircle the entire cone, subepithelial scarring, Voigt's stria, or high drops. The apex is usually inferior to the horizontal meridian. It can also be located centrally. prominent corneal nerves have been reported as an early sign of keratoconus. Corneal nerves have an important function and are required for epithelial cell regeneration and wound healing after corneal injury. In confocal microscopy findings of keratoconus patients, in the epithelium, wing cell nuclei and basal cell diameter are significantly greater than normals. In the stroma, increasing levels of haze have been shown to be associated with a reduction in the apparent keratocyte density. This relationship was of a much higher significance for the anterior stroma than the posterior stroma. The degree of stromal haze has not been shown to bear any relationship to the disease severity as classified by corneal curvature. Reduced keratocyte density may be associated with corneal thinning. Keratocytes are known to be responsible for the production of extracellular matrix. Therefore, it is possible that reduced number of keratocyte density is secondary to the process of corneal thinning. In the endothelium, keratoconus patients have a greater endothelial cell count than controls, but there is no difference in pleomorphism or polymegathism. Histopathology of keratoconus shows an irregular corneal epithelium, an accumulation of iron particles in the basal epithelium, fragmentation of Bowman's layer, electron-dense PAS positive material in the stroma, and tears in Descemet's membrane. Scheimpflug and OCT measurements are reproducible but always thinner than ultrasound pachymetry measurements in both normal and keratoconus suspect eyes. Anything below 530 microns is suspect for keratoconus. However, many practitioners are only alarmed when it goes below 500. The management of keratoconus can be grouped into medical therapy, such as eyeglasses and contact lenses, procedures which weaken the cornea, such as penetrating keratoplasty, thermokeratoplasty, excimer laser photorefractive keratectomy, and LASIK, or procedures that reinforce the cornea, such as lamellar keratoplasties and epikeratophakia, intacts, and collagen cross-linking. In this module, we are going to be discussing procedures that reinforce the cornea. Collagen cross-linking is one such procedure. It is hoped that collagen cross-linking will halt the progression of keratoconus and reduce the need for further PKP. Collagen cross-linking is done by applying 0.1% riboflavin drops to the anterior surface of the eye. The eye is then irradiated with 365 to 370 nanometer UV light for 30 minutes. During this procedure, the proteoglycans cross-link the collagen fibrils. During the post-op healing phase, there is no persistent defects or scarring. The cornea and lens retain their transparency. The endothelial cell density remains stable, and the IOP is unchanged. Collagen cross-linking results in flattening of the steepest K by approximately 0.74 diopters at 3 months, 0.92 diopters at 6 months, and almost 1.5 diopters by 1 year. There is a trend towards improvement in best-corrected spectacle visual acuity. There is no statistically significant changes in spherical equivalent or endothelial cell density. Preliminary results suggest, at least a temporary, stabilization after cross-linking treatment. Patients are often interested in intacts. Intacts are clear PMMA rings that are inserted at 2/3 depths into the cornea. Intact thickness affects the amount of myopia reduction. The thinner the ring, the less myopia reduction. Think of the keratoconus cornea as a sagging hammock. When the intacts are placed in the midperiphery, the vector forces cause a tightening or flattening of the central region of this hammock or cornea. Intacts should be considered in patients with contact lens intolerance, who have a clear cornea with no scarring, visual acuity greater than 20/50, and corneal thickness at the site of the segments of at least 450 microns. Contraindications for Intacs include corneas with central scars and opacities, or corneas that are too thin at the site of the Intacs. During the post-surgical recovery period, patients will complain of glare, halo, photosensitivity. Vision will fluctuate, and they will say that vision is better in the morning than in the afternoon. They will also complain of foreign body sensations. There are known complications associated with Intacs, including deposit along the tract lines, perforation, neovascularization along the tracts, glare, infectious keratitis, and irregular astigmatism. Deep anterior lamellar keratoplasty is a partial thickness keratoplasty. During the DALK procedure, the stroma is removed up to Descemet's membrane, which is up to 98% of the depth of the cornea. Donor tissue is then placed in the bed of the cornea and sutured in place. Advantages of the DALK procedure include no open sky surgery, meaning that the anterior chamber is never opened. The endothelium is maintained. There is easier post-op management and less astigmatism. There is a decreased risk of allograft rejection and decreased risk of long-term complications. Disadvantages include a greater necessary surgical skill, possible perforation and then necessary conversion to PKP, suturing problems, irregular astigmatism, infection, and interface haze. Risks associated with DALK procedure include Descemet's perforation, which result in conversion to a penetrating keratoplasty in 9 to 14% of cases. Epithelial rejection occurs in 2 to 15% of cases. Stromal rejection is very low in only 1 to 2% of cases, and infection rate is only 0.8%. This concludes the scientific module on keratoconus. I hope this program has been informative and will aid you in your discussions with your keratoconus patients. Keratoconus patients are often interested in the backgrounds and science behind their disease. Please join us for other keratoconus modules.